Hello and very good evening, everyone. I welcome you all to this very sought after session. Many students had given me message that sir, please start with epidemiology. Please do epidemiology. So here we are, and today we are going to discuss epidemiology with screening of disease and with questions from Biostats. So, how was your preparation? Are you still able to cope up with community medicine? This is the session number 6. So total, we were supposed to do total 7 sessions. Out of 7 sessions, this is just the second last session. In the next last session, we'll be just discussing health indicators, miscellaneous questions, and some of the very recent updates, which probably we did not discuss in the previous 5-6 lectures, and all the lectures will be available to you online till the time you have your exam. So it will be available till whatever time, like in the first week of March or the second week of March, the lectures will be available to you. So very good evening, Pranav. Hi, Lakshmi, Sukhbir. A very good evening to everyone. So let us now start with our discussion. And as usual, as always, we will be discussing some of the important salient MCQs, selected MCQs. These will be relatively okay types. So there was one MCQ which I could not discuss in the previous session, so I'm doing it right now. Secondary attack rate is calculated from minimum incubation period, maximum incubation period, average incubation period, or any of the above. What do you think you're going to say in this? So yes, Pranav, we are towards the end of the community medicine marathon. Yeah. Hi, Badshah, Trailer Badshah. क्या नाम है भाई? शुभम जाना. Very good evening. क्या लगता है इसका आंसर बेटा? Secondary attack rate is calculated from minimum incubation period, maximum incubation period, average incubation period, any of the above. So what do you think you're going to say in this? Any idea? Yeah, people are saying maximum incubation period. Maximum incubation period. I know that is the reason मैंने ये question डाला था. This is the main reason for which I had put this question. This was supposed to be a googly question. So anybody who would like to change the answer, you have another chance. You have another lifeline. You want to change the answer? What do you want to say? Option B. Yeah, many going with B. Ashma says C. So beta, secondary attack rate, the definition of secondary attack rate, you can just after this lecture, just visit the Park textbook and have a look at the answer, like what is secondary attack rate. So that I know this is a very bekar raddi MCQ. I am not of the favor of this MCQ, but this MCQ had been asked and it will be asked. It may be asked again. So what the googly question over here is, the problem with definition of the secondary attack rate is that secondary attack rate, it is given as the definition. It is the number of secondary cases arising within the range of the incubation period. I know I look so stupid while writing this definition. It is the number of secondary cases arising within the range of the incubation period divided by the total susceptible cases or susceptible population, not the cases, susceptible population multiplied by 100. This is the technical definition of secondary attack rate. This is the technical definition of secondary attack rate. So it is the number of secondary cases arising from the range of the incubation period. I know there's a bad definition, but it is the range of the incubation period. So what do you mean by the range of the incubation period? Range means from the minimum incubation period to the maximum. I wish I was wrong, but the best answer over here is any of the above. It includes minimum, it includes maximum, it includes the average incubation period also. Secondary attack rate is calculated from. So it's a tricky MCQ, no doubt. And beta, this is just for you all to know that your concepts are absolutely fine. I like your concepts. बिल्कुल ठीक कह रहे हो. So whoever has answered, whatever your answer is, A वाला भी सही है, B is also correct, and C is also correct. Are you getting it? So it's just the way the MCQ was framed. So this is a googly question. Anyways, it was just a small question for me to discuss over here. Okay, this I know it's a bad definition in Park textbook, and that's how it goes. So anyways, let's move to the next question. Let's move to some serious questions from epidemiology, screening of disease, and biostats. Okay. Question number 2, in fact, but in fact, this should be question number 1. Screening of carcinoma cervix is. What do you think is a screening of carcinoma cervix? It is health promotion, specific protection, secondary prevention, or tertiary prevention. So what do you want to say? What is it? Screening for carcinoma cervix. So absolutely correct. All those who have answered it rightly. So please note that screening could be of broadly categorized into 2 types. You can have a presumptive screening, or we can have a prescriptive screening. The presumptive screening, it is also called as presumptive screening, is also called as a predictive screening. It is also called as a predictive screening. The predictive screening or the presumptive screening, these are primary prevention, whereas the prescriptive screening, these are technically the secondary prevention modalities. Examples of these you should be knowing. The prescriptive screening example is anything. You're going to screen for cancer of the cervix, you're going to screen for cancer of esophagus, cancer of head and neck, lip oral cancer, screening for tuberculosis, screening for diabetes, screening for HIV, screening for any disease in the world based on the signs and symptomatology of disease, that will be technically called as prescriptive screening. So screening for diseases based on sign and symptoms is what is secondary prevention. So please note that basically you are doing early diagnosis of the disease. Basically we are doing early diagnosis of the disease. Whereas in predictive screening, we are doing primary prevention, and in primary prevention, example for primary prevention modalities could be where you are preventing a disease. So the main focus is prevention of disease. How are you going to prevent a disease? So example for this would be like for ANC cases. For example, for ANC cases, we do HIV screening. We do like annual medical checkups. So everything is a predictive screening. Next, I would also like you to know another point very frequently. This is a 7-star MCQ point for you. So there are different levels of prevention, as you can see on the screen. You can have a primordial prevention up there on the top. Then you can have a primary prevention, secondary prevention, tertiary, and there is something called as a quaternary prevention. So there are different levels of prevention, beta. So in the primary prevention, the main thing that you need to understand is that the risk factor is not allowed to happen. So there is no risk factor. You leave the risk factor. You do not let the risk factor to come up. That is what is primordial prevention. Examples for this could be predominantly we want to have health promotion, that the person is already in good health and you want to just promote the health of a person. Example for this could also be a lifestyle modification in a person who does not have a disease. If a patient is already having disease and then you're doing lifestyle modification, that's actually a treatment for that disease. So I got this question on Telegram group yesterday only. It was a good question and it was discussed much in detail. So please note that lifestyle modification in a healthy person, that would be technically taken as a primordial prevention. You all are young students. So your age would be like somewhere in 20s, 30s, or maybe in early 20s or late 20s, whatever. So you are currently probably, presumably, you are not at risk. So, if I ask you to do yoga, to do breathing exercise every day, and probably to do physical exercise at least for 15-20 minutes a day, every day. So, I'm trying to promote your health. So, that is a primordial prevention. When you will become 40 years of age, at that time it becomes kind of a necessity for your life to have a physical exercise, otherwise your joints start aching. So at that point, when somebody would tell you that you would please do physical exercise, at that point, that technically becomes a primary prevention, because you're already having a risk factor, that is your age. And then you're doing lifestyle modification, that's a primary prevention. But when, for example, somebody gets a cardiac disease or obesity or any diabetes, and then we ask them to do lifestyle modification, that's actually a secondary prevention, because that's the treatment modality of that particular disease. We want to have check in the dietary intake. You need to have dietary modifications and physical exercise, right? So all these are important stuff for you to remember. Just remember that primordial prevention is no risk factor, and primary prevention is that the risk factor is present but no disease. We are going to prevent the disease. Secondary prevention is early diagnosis and treatment. Tertiary prevention is disability limitation or rehabilitation. What is specific protection? Very good question, beta. That specific protection, PARC textbook, I am not very happy with the PARC textbook. I'm not very pro with the PARC textbook, but it's a wonderful book because it contains so much amount of syllabus, and everything is there. Everything is discussed much in detail. So that's the reason I somehow have to take up this PARC textbook. Now, PARC or some other authors also are of the opinion that there is something called as a specific protection. So what do you mean by specific protection? Specific protection, it's a specific words towards prevention of a specific disease. So what happens is, let us say you do some activity, you do physical exercise, you do dietary modification, you are preventing obesity, you're preventing hypertension, you're preventing cardiovascular disease, you're preventing cancer. If you're not smoking, you are preventing hypertension, you are preventing so many things. So these are general prevention modalities, but there are also called as specific protection modalities. For example, immunization. If you get immunized with measles vaccine, you're going to prevent measles disease. You're not going to prevent chickenpox disease. So for prevention of COVID, you need to take COVID vaccine, not a measles vaccine. So that is called as a specific protection. Just remember that specific protection, it is a type of primary prevention. You want to prevent the disease with specific interventions. So what is your best answer over here? Screening of cancer cervix is a type of screening of cancer cervix. You are screening the disease based on the symptomatology. That is called as a secondary prevention. Why? Because you are going to do early diagnosis and treatment of the disease. You're going to do early diagnosis and treatment of the disease. So yes, Chakravarti, it will come under the specific prevention. It will come under the primary prevention. Absolutely correct. Let's move over to the next question. Yes, all are examples of nutrition, vaccination, defluoridation. So all these would be coming under primary prevention. Okay. What's your question, Ashma? If somebody accidentally drinks water contaminated by dog or cattle, does he need ARV prophylaxis? No, it's only after the dog bite. That's what the guidelines say. Anyways, let's move ahead. While conducting a study, many respondents are invited, but some are not able to come. What is this called? What do you think? I couldn't get what your question was, Dr. Ashma and Dr. Shoaib, NVBDCP. What do we want to say in your comment? So anyways, if everything is okay, we can just move on. While conducting a study, many respondents are invited, but some are not able to come. This is called as response bias, volunteer bias, selection bias, Bergsonian bias. What do you want to say? Yeah, I'll be talking about your the question about your comment about breast self examination. I'll be discussing that. Let's first do this MCQ. Mm, while conducting a study, many respondents are invited but are not able to come. So, what are you going to say? Please note that this is not a volunteer bias. It is not a volunteer bias. It is not a volunteer bias. Volunteer bias is something else. I will discuss with you about the volunteer bias. What do you mean by anything else that you want to say? You want to change your answers? Everybody is answering B over here. Naved, Gopal, Chakravarti, Nanda Kishore, Anju, Babu. You want to change your answers. While conducting a study, many respondents are invited but are not able to come. So some students would go with selection bias. Ashma says A. Anything else you want to say? Now A's have started coming. So, देखो बेटा, it is very simple to understand. Whenever we conduct a study, people will be there who will be joining the study, and people will be there who will not respond to your study. So this type of bias where you invite people and they are not able to join in, this is a valid answer. This is called as a non-response rate. This is called as a non-response rate. What do you mean by a non-response rate? Non-response rate means that you invited somebody and they could not come back. So this non-response rate is a valid term. It is usually said that the non-response rate should be as low as possible, but never more than, not more than 8 or 10%. If it is more than 8 or 10% or 20% or 15%, that somehow is taken as a bad type of study. We don't say bad type of, the relevance of the study would actually decrease. That why is there so much big non-response rate? So any non-response rate which is within 8 to 10% range, 2%, 5%, 10% non-response, that's okay. So most of the studies would take the category or would take the upper limit as 10% of the non-response rate. So this is called as a response bias. So non-response, it's actually not a response bias, it's a non-response bias. Why is it not a volunteer bias? What do you mean by a volunteer bias? There is something called as a healthy volunteer effect. Healthy volunteer effect. And this is what is a volunteer bias. This is what is a volunteer bias. What do you mean by a volunteer bias? Let us say that you all are doing a study. Let us say, let's take COVID only. Let us say that you all are doing a study to find the adverse events following COVID immunization. So let us say that you are going to conduct a study. So how will you conduct a study? So you immunize everybody, and then let us say that you just put an advertisement in newspaper, or you just put a post on social media that I want all the people who have taken a vaccination, and they should come back to my center, or they should give me a call, or they should email me. They should contact me somehow by telling that was there any adverse event, yes or no. So if you do, you make a post on social media, or you do a advertisement somewhere, you give a advertisement somewhere, or you make a post on social media. So what are the category of people that we are usually going to get? The category of people that we are usually going to get for this type of study, for COVID immunization with adverse effects, there is a high chance that you're going to get healthy people who did not get any adverse events. So people who got adverse events will be very less. So whenever you are asking for volunteers, there is a very high chance that only the healthy people or the people who did not have the event will report to you. This is called as a volunteer bias. This is called as a volunteer bias, and it's not the correct answer over here. Selection bias is just like you do selective allocation to different groups. Bergsonian bias. What is Bergsonian bias? It's also not the correct answer. Bergsonian bias is what? It is differential hospital admission rates. It is a very specific bias found in case control studies. Case control studies which are hospital based. Hospital based case control studies will have a Bergsonian bias. The correct answer, I think, over here should be a non-response bias or a response bias. Non-response bias or a response bias. Let us move over to the next MCQ. Okay, before I move over to the next MCQ, there are a couple of questions now. So let's take some of the questions. Sir, breast self-examination is what type of screening? If a female is doing self-examination, or if a female gets a clinical breast examination done, so anyway, what is the main focus? What is the main focus of doing breast examination? Beta, the main focus of doing breast examination, any type, so breast examination, any type, it could be self or it could be clinical based. You are going to find lump or any mass or any shape abnormality. That's what the person will be doing. That's what, even if it's a nurse or a health worker or a doctor or a oncologist, so they are going to palpate to find the lump or any mass or any shape abnormality. So that's the main focus. What is the objective? What is the objective of doing this? The objective is to find cancer in case it is there. So to find cancer in case it is there in early stages. In early stages. So predominantly, what are you doing? You are doing a secondary level of prevention because you are doing you are going to treat the disease at an early stage. Next question that we can take up is prescriptive screening comes under secondary prevention breast cancer for own benefit. Absolutely correct. Early diagnosis, secondary prevention, secondary. Absolutely correct. Secondary prevention is the correct answer over here. Any other doubt you have? Anything else you wanted to ask in this question about prevention modalities? I think we are all done. So in case you have any doubt, you're most welcome to ask on this in this chat only. There was one question like you also didn't ask me, what do you mean by a quaternary prevention? So quaternary prevention, it's a specific term which is used for overdiagnosis. So many times because we study more, let us say that I get generalized weakness or sometimes I get runny nose also, and very light grade of fever also. If I get maybe 2 or 3 times a year, I just go to my doctor to ask him that, sir, what is happening to me? I've got runny nose, some little fever and body aches are there. They go and test rather than diagnosing me as simple influenza or common cold. They diagnose me with maybe tropical eosinophilia or some rare disease. So many times what happens is that we tend to overdiagnose. Prevention of overdiagnosis is called as a quaternary prevention. It's a new term which has been added into the books. So that can also be asked. But sir, if breast examination is done, isn't it primary? Beta, primary prevention is to prevent disease. Beta. So whatever your name is, I'm sure your name is not Phantom Dog. But beta, the modality of doing breast examination, so a female is palpating her breast. So the main thing is that to find out, is there any lump in the breast? So if a female is able to find a lump, that means that she should get herself screened. That could be a simple fibrous collection, or there could be simple adipose tissue, or it could be cancer also. So you're trying to find the disease in early stages. It is a secondary prevention. It is not primary. You don't prevent cancer by doing self-examination. So, okay. Yes, Nandakishore, that's what I wanted to say. You are not preventing breast cancer from happening by doing self-examination. But let's move on to the next MCQ. So I think everybody is waiting for the next question. A 35-year-old female presents to office due to a self-palpated breast mass. That's the same problem now. So after an appropriate workup, a fine needle FNAC of the mass was performed. The results of the FNAC return as negative. So the FNAC is negative. As you're explaining the test result, the patient asks, what are the chances that I really do not have breast cancer? Which of the following best addresses this patient's question? False negative rate, specificity, positive predictive value, negative predictive value? What do you want to say for this question? So what are we going to calculate for this question? Anybody who would like to answer to this? So it's a fairly simple question. The test results are negative. So as you're explaining to the test result to the patient asks, what are the chances that I really do not have breast cancer? So what are your answers on this? Anybody who would like to answer? Anything? It's a false negative rate. It's a positive predictive value. Shoaib says D, negative predictive value. C, positive predictive value. Soumeshri, D, C, D. So it's all your answers are hovering between C and within option D. So see, just 2 minutes on this, you already know from your previous understanding for screening of disease that there is a table like this that you can make. So you can make a table like this. On the top, please remember, always have the disease on the top. On the top, the disease should be there. On the left side, the test should be there. So whenever the disease is there, I'm just talking of this column. So if you talk of this column only, if you talk only of this column, the disease is there. In the disease, the test could be there, positive, or the test could be negative. If the person already has a disease, and the test is negative, so we call this as a falsely negative test result. But if the patient is healthy, can you see this? In this column, the patient is healthy. So if the patient is healthy, but the test should be negative, right? It's a true negative. But what if the test is by chance positive? That is called as a falsely positive. So whenever the disease is there or not there, test is there, not there, you get a true positive, true negative, false positive, false negative. Please remember for your exams that the probability of having true positive, very important. This is a 7 to 10 star MCQ slide for you now, beta. Whenever we are talking, the MCQ says the chance of having true positive out of the total disease, that is true positive divided by D plus. This is called as sensitivity. True positive divided by the total disease, this is called as sensitivity. If the question is saying true negative out of the total healthy, this is called as specificity. So what is specificity? It is nothing but true negative divided by D minus, total healthy. Okay. Now, based on this understanding, let us look at the table from left to right now. Left to right. So if you talk about true positive, out of the total tested positive, if you look at the true positive out of total tested positive, so if you look at the true positive out of total tested positive, out of this whole thing, so true positive divided by true positive plus false positive, this is called as a positive predictive value. It is called as a positive predictive value. And if you look at true negatives, if you just look at the true negatives out of total tested negative, true negative out of total tested negative, true negative divided by tested negative, this is called as a negative predictive value. So just remember that we are always talking of true positive or true negative. If it is true positive, you please write in your chat box. Please write in the chat box. Let me see if you are able to write it. So please answer. I'm asking you questions. 4 questions I will ask you. If true positives I see, I have 2 options, option A, option B. Can you tell me what is option A? True positive divided by D plus. Or I can have true positive divided by test plus. So what is true positive divided by D plus called? Can you tell me what is A? And can you tell me what is B? True positive divided by test plus. If I, on the other hand, look at true negatives, I can have C, I can have D. So what is D? C, that is true negative divided by D minus, or I can have true negative divided by test minus. Can you tell me what is the answer to C and what is the answer to D? So please write down what is the answer to A. A is what? It is sensitivity. Absolutely correct, beta. It is sensitivity, and this one is positive predictive value. Everybody is answering correctly. Can you tell about the C and D? What is C and D? What is option C? What is option C? True negative by D minus and true negative by test minus. What is option C? C is absolutely correct. It is specificity and true negative by test minus this negative predictive value. Negative predictive value. Absolutely correct. So if a person comes to you, this question is saying very easy stuff. The question is saying that the person is having, you can delete everything, you can just mark this word, that the result of the FNAC is negative. That means the test is negative. So as you're explaining, the patient asks, what are the chances that I really do not have breast cancer? So what are the chances that a female is disease negative if test is negative? So what are you going to calculate? Don't you think you're going to calculate the true negative divided by test negatives? So true negative divided by test negative, answer is negative predictive value. Answer is negative predictive value. Absolutely correct. So many of you have got this answer correct. The answer to this is negative predictive value. Let us go to another MCQ. All are true of the randomized control trials. Hakuna Matata sir, can you explain how false positive value is affected by sensitivity, specificity and prevalence? That will be a long story. I will try to explain it towards the end of the session. So just when we are towards the end, we will discuss that. Anyways, let's move that on, and I will be discussing this. Before we proceed, just to address this query which has come about the false positive. So please note that false positive, just to make you cram this stuff, I will help you in understanding later on. So just for now, take this, that false positive may be high. So you can have higher false positives. So you can have higher false positive in what scenarios? So false positive will be higher in what scenarios? False positive will be higher in case of low specificity. False positive can be higher in case of low sensitivity. High sensitivity. Low prevalence. It is in case of low prevalence. Low prevalence, or it could also be in cases of high sensitivity. So just remember that these are the three scenarios in which cases the false positive will be higher. We will be discussing how to obtain this in the last, in case we have time. So for now, just remember and cram these numbers. If you get the single best answer, the single best answer is low specificity. Second best answer would be low prevalence. And third in line would be high sensitivity. Okay. So why it's not false negative error rate? Very good question, Chakravarti. Why is it not false negative error rate? In case this question had asked that the patient is already healthy, what are the chances of this patient to have a negative test? The chance, listen to these two statements now. The probability of having no disease, the probability of having no disease if the test is negative. So your test is negative, what are the chances you don't have disease? Second statement, the probability of having a test negative if the person is healthy. You know that the person is healthy. What are the chances of having test negative? Can you write down in this like option A or option B? What is option A? What would you fill in option A? That was a good question by Chakravarti. So what do you think you will write for option A? The question is saying that the probability of having no disease if the test is negative. You already know that the test is negative. So what are you going to write down? What is it? Probability of having test negative if healthy is specificity. So Shoaib says correctly. My question is, what are you going to write in option A? The probability of having no disease if the test is negative. What are you going to write down? If the test is negative and you already know that the test is negative, what are the chances this patient does not have disease? The answer would be a negative predictive value. But if the question is saying that the person is already healthy, so out of healthy, this should be specificity. Am I correct? This, what they are asking is true negative divided by D minus. What is this? This is true negative divided by test minus. Are we able to understand? So I think many of you already know it. So Dr. Chakravarti, just try to practice a little bit more and you will be able to get a hold on this question. Let us move to the next MCQ. All are true of the randomized control trial except. So all are true of the RCT, randomized control trials, except groups are representative of the population. Randomization is done to have an unknown chance of allocation of subjects. Both study and the control group should be comparable. In a single blind, the doctor does know of the group allocation. So what do you think you're going to mark in this question? So all are true of the randomized control trial except groups are representative of the population. Randomization is done to have unknown chance. Both study and the control groups should be comparable, and in a single blind trial the doctor does know of the group allocation. What do you think is the best answer over here for this question? So study group is given and intervention and control is not option C. Okay. This is a very simple MCQ. I don't think you need to bang your head anywhere. So some students are going with option C. Some are going with option D. In a single blind trial, the doctor does know of the group allocation. Nanda Kishore says B. Anju Babu, D, B. So we are hovering around B and D now. Many of you are, this beta is question is all except. So the question is about all except. Do you think that what is a single blind trial? Single blind trial, the doctor does know of the group allocation. In a single blind, who is blind? The doctor or the patient? So the doctor should be knowing about the allocation. Yes or no? What do you think? What do you think on this? So many of you are answering option B. Groups should be representative of the population. Randomization is done to have unknown chance. Both study and control groups are comparable single blind. It's a very simple question. I think many of you have just got the concepts ulta pulta. But anyways, it's a very simple direct question. Yeah, Shoaib is correct. Randomization is known and equal chance. So yeah, in single blind only patient is blind. So let us move from the options now. Groups are representative of the population. So all are true about randomized trials except you have to find the false one. Groups are representative of the population. That is true. We want the group should be representative. Otherwise there will be problem with the bias. So there will be problem with the sampling. So that's basically a sampling error. Sampling error will come. Otherwise the sampling error will come. So this option A is true. I'll come to option number B. Randomization is done to have an unknown chance. Please know that what is a randomization. Randomization means you have to cram this by heart. It is to remove a selection bias. Randomization is done to remove a selection bias. It is done at level of allocation to groups. It is done at the level of allocation to the groups. And randomization, it means what? It means you have to mark it by heart that randomization means unknown. It means a known chance and equal chance. It is not unknown chance. It means a known chance. You know the chance and it should be equal every time. That is what is randomization. So if you talk about randomization is done to have an unknown chance, it is not unknown chance. It is a known chance. It is a known chance of allocation of subjects to different groups. That is correct. So this option B is false. This is false option. This is the false one. Both study and control group should be comparable. Many of you got confused in this option. Both a study and the control group, they should be obviously technically comparable here. How can you do a randomized control trial to check for maybe any drug which acts on finasteride, which acts on probably prostate? So you're checking any drug which is specific to prostate, and you take two groups, males and females, and you give them the drug. How nonsense this study will be. Whenever you plan a study, you cannot compare apples and oranges. They have to be comparable, beta. So option C is big time true. It is one of the main statement that both the males, both the groups, the group A and the group B, should be always comparable. You cannot have two groups with males and females in different populations. So that's absolutely true. They should always be comparable. This is correct. In a single blind trial, the doctor does know of the group. Yes, technically, I think everybody knows this answer. So what is blinding? Blinding can be of three types. We can have single blind, double blind, or triple blind. Single blind is only patient or the subject is blind. D for double, D for doctor blind plus patient blind. Triple blind, you have the analyzer plus the doctor plus the patient or the subject. They all three are blind. This is the triple blind. Triple blind is common sense, the best type of blinding. Double blind is the most common type of blinding which is used. Are we okay? So it's a very direct question. So D option is also obviously correct. There is no doubt in this. So which is the best option that you're going to mark as your answer over here? The best answer we would like to mark is randomization is done to have unknown chance. This is the best option. Why? Because it is all except. Okay, let's move over to the next MCQ. Match the following. This question was also posted online on many of the social media groups, and just wanted to have your views on this question. Like, what do you want to say on this MCQ? Match the following. Recall bias is what? Hawthorne effect is what? Rare and expensive investigation. Randomization is not required. Option 5. Population attributable risk is calculated in which study? 6. Using historical methods to find people with or without disease, with or without risk factor, and population based study. What do you think you're going to mark for option A? So what do you think is A, or the first one, recall bias? Recall bias is matching with what? So if I'm talking about the recall bias, let us talk about the recall bias. Option number 1, recall bias. Recall bias means a differential ability to recall between cases and controls. It is a specific bias found in a case control study. MCQs on case control study that you would like to remember for your exam. Case control study is a study which is almost always a retrospective study. In a case control study, we find out odds ratio. Odds ratio is given by the formula A into D over B into C, AD by BC. So that is what is odds ratio. It is also called as a cross product ratio. In a case control study, you go from cause to the effect, or you start from the effect and you go towards the cause. We start from the effect and we go backwards to find the cause. So it is called as effect to cause. It is effect to cause study, it is always backwards in time, and it always involves interviews, and there is element of recall bias. So these are couple of MCQs you need to memorize on a case control study. Next, let us talk about what do we mean by a Hawthorne effect. Next is, what do we mean by Hawthorne effect? Hawthorne effect. Hawthorne effect. Hawthorne effect is nothing very special. It is a change in attitudes, change in behavior, oblique attitudes while under observation. It is change in attitudes while under observation. That is what is a Hawthorne effect. So technically, when will you do observation? You are going to do observation in what scenario? You are going to do observation in a cohort study. We will do observation in a cohort study. We will also do observation during randomized clinical trials. So whenever we do trials, whenever somebody observes you, whenever you observe anyone, that anyone will change the behavior. When parents or teachers will observe you, you will change behavior. So there is a change in behavior whenever we do observation. MCQs now on cohort study. Absolutely correct, Roy Chaudhary. Hawthorne effect is change in attitude, study in RCT and cohort. Absolutely correct. Wonderful concepts. So MCQs on cohort study. A quick brush up about the MCQs on cohort study. Cohort studies are usually prospective, but they can be retrospective also. Usually the cohort studies will be prospective. So technically, if you talk about cohort study, it's a prospective cohort study. So talking about the prospective cohort studies, they are going from effect to the cause. They are going from the cause to the effect, or from the effect you go backwards to the cause. We start with people with risk factor. So you go from cause to forward looking study to the effect. So basically it is a cause to effect study. These are of course going to take a long time. They are more expensive studies. But a few other MCQs on this is, in cohort study, we can find out a relative risk. We can find out attributable risk. And we can find out population attributable risk. So we can find out relative risk, attributable risk, and population attributable risk. What is the formula for relative risk? Relative risk is given by the formula incidence in the exposed population divided by incidence in the non-exposed population. What is the formula for attributable risk? Attributable risk is given by the formula incidence in the exposed minus incidence in the non-exposed divided by incidence in the exposed group. What is the formula for population attributable risk? It is incidence in the total population minus incidence in the non-exposed divided by incidence in the total population. So population attributable risk MCQ is the most important attribute while making national health programs. So whenever we talk about the national health programs, any risk factor if the program is trying to address to, if you're trying to decrease obesity, what is the population attributable risk of obesity on cardiovascular morbidity? So we have to find that out. We have to determine that. Only then you're going to spend money to stop obesity. If you think that the population attributable risk of smoking is very high in cancer, you have to calculate that, and then only you do a national program for stopping tobacco smoking. So whenever we are planning national health programs on bigger community level basis, we are going to talk about the population attributable risk. Otherwise, please note that you can calculate the risk ratios, you can calculate attributable risk, you can calculate population attributable risk. Next MCQ is that within the cohort study, in this cohort study, there is a specific type of bias. The bias is there in Hawthorne. One is Hawthorne. You can also have attrition bias. What do you mean by attrition bias? What is attrition bias? It means that the people will be joining the study and then they will leave the study. So there might be people who are joining this video session and then they leave this video session. So people who leave the video session or people who leave the study, those people are technically called as attrition. That is loss to follow up. So that loss to follow up is there. Loss to follow up is there. So it's a very important attribute in, it's a very important bias in a cohort study. It is called as attrition bias. Also, we can have selection biases, Hawthorne effects. We can have so many things. So absolutely correct. These are called as dropouts. That's a much better word for me to say. Thank you so much, Someshwari. And that is what is dropouts. So thank you for being attentive in the videos sessions also. So these are a couple of questions on cohort studies. So for a recall bias, I would like to mark this recall bias should be with the case control study. So 1 goes with D. Hawthorne effect, just now we studied, it goes with the cohort study design. So 2 goes with A. So what are there for rare and expensive investigations? That's a catchword over here. We are talking of the investigations. So please note that there is a study that is called as a nested case control study. Direct MCQs on nested case control study design. Nested case control study, it is a type of a cohort study. Nested case control study will give you both elements of odds ratio and relative risk in a single study. You're doing a case control study within the cohort study. So that's what is advantage of a nested case control. Nested case control is one of the study of choice for rare and expensive investigations, or a rare and expensive test. We do a study called as nested case control. So please note that nested case control is one of the best study for rare expensive investigations. I would also like to point out over here that sometimes the MCQ may be asking you about the study of choice. Study of choice to find prevalence. What do you want to say? A cross-sectional study. Study of choice to find odds ratio. It is case control study. Study of choice to find incidence. What will be the answer to find the incidence? It is a cohort study. Study of choice for rare diseases. Study of choice for rare risk factor. Study of choice for rare investigations. What do you want to say? For rare investigations, for rare risk factors, what is the study of choice? So for rare disease, beta, the study of choice will be for rare diseases. The disease is rare. So you find the people with those rare diseases and you ask them, do you have this risk factor? Do you have this risk factor? What about this risk factor? So that's technically called as a case control study. For rare risk factors, you take people with risk factors and then you follow them for having a disease. So that is actually a cohort study. And for rare investigations, we do a nested case control. Just now we learned about nested case control. So these are some of the questions which can be asked about a study of choices. So for rare expensive investigations, I would like to go with the nested case control. So 3 goes with option number B. Randomization is not required in this experimental trial. So technically, whenever we want to do randomization, I told you about randomization. Randomization is a known and equal chance. It is a known and equal chance. So equal chance of what? Of allocation. Of allocation into different groups. Let us say there are group A and group B. So you should have a person who is randomly allocated into group A and randomly allocated into group B. That essentially is what is randomization. So randomization is only possible when you're talking of 2 groups. So there is a study called as a pre-post study. So what is a pre-post study? In this, there is only one group. There is only one group of students to those students, I gave them a test before my lecture, and then after my lecture, I gave another test, like the similar test, after the lecture. So what was the average marks of all the students before the lecture, average mark of the students after the lecture? So this is a pre-post study design. You take a group of 100 individuals, you check their blood pressures before, then you give them some medications and you check their blood pressures after. So you're talking about single group. There is no way that you can randomize. There's no possibility of randomization because there's only one group. Randomization minimum would require two groups na yaar. And a simple question. So what is a randomization is not required in this experimental trial. I would like to mark option C over here. So 4 goes with C. Population attributable risk is calculated. Just now we discussed that population attributable risk is calculated in cohort studies. We go with option A. Using historical medical cohorts to find people with or without risk factors. I would like to point out over here that when we are discussing about something called as a retrospective cohort study. So whenever we are talking of a retrospective cohort, what we do is we go back in time to find people with a specific risk factor, yes or no. So let us say that you're talking of people who were exposed to a lot of brick smoke, or people who were exposed to a lot of heat in the bricklin factories where people make brick. So you want to find that people. So what you can do is you can go to a brick factory and take people, labor who's working there, and try to follow them for the next 5 to 7 years to find out how many people develop some lung problem. Or what you can do is you can go to that brick factory and ask them to give the list of the employees that they had. They will be labor class. That will be very difficult to do. But just theoretically, I'm saying, what if they have a list of the laborers which were working with them, with their mobile numbers and Aadhaar card numbers and everything? So you call those people who were working with them 5 years back or 7 years back. And then you just give them a call today that, how are you? Any lung problems do you have? This type of study where you go back in time to find a group, special group with a specific risk factor, that is called as a retrospective cohort study. So you go back in time to find people with the risk factors. Whenever there's just a small trick for you, I'm not very pro in this, but there's just a very small trick for you that retrospective cohort MCQ will be that medical records will be taken. Medical records were taken, historical medical records were taken, and the specific group was found out. That will be called as a retrospective study. Sir, NEET 22 be delayed. News has just come. Wow. Is it? I'm not very sure. Is it real that the NEET 22 is delayed? Last time when I was taking a class, at that time, the live session only, at that time I think the news was there regarding the prospectus was there for NEET exam. So right now people are saying about the NEET 22 is delayed. I don't know. I'm not sure. I'm busy with the learning stuff. For you also, I would always suggest that, I know it is very difficult and it's easy for me to say, it's very difficult for you to take it on, that you should be focusing more on your studies, right? Official notice yet to come, not official. Yeah, that's what I think. Okay. Health ministers has accepted. Wow. If it is delayed, it's, I don't know. It's always both ways. Whenever an exam is delayed, it will cause dampening of your effect. Many students will just feel dampened that, yeah, I had studied so much. Now who's going to study for next 2 months or 3 months? There will be a category of students who says, yes, it is delayed. Now at least I have 2 months extra. I was not able to finish community medicine. At least now I'll be finishing community medicine, or any XYZ subject, or biochemistry or pharmacology or medicine, or of course nobody leaves medicine, but any subject. So so just remember, let's come back to the MCQs and finish off this session, and very fast. Population attributable risk, we discussed it is option A. Historical medical cohorts, I would like to go with historical medical cohorts would be with retrospective study design. So 6 goes with F. 6 will go with F. So population based study. A population based study, it's a direct question, and I think many of you must have answered about it correctly about the population based study. That is a study, special study called as ecological study. Ecological study design. What do you mean by ecological studies design? Beta, the ecological study design, it's a population based study. Population based study. What do you mean by the population based study? Population based study means, let us say you are going to find the possibility of eating more and people develop cardiac disease. So one is that people eat more and you find cardiac disease. You take a group of people who are obese and you find the chance of cardiac disease in time to come. That is a cohort study. Or you take people who are with the cardiac disease and you ask them, do you eat more? You ask about their nutritional habits. That is a case control study. Or what you can do is you can take the average food consumption of a country and find the average heart attack rates or coronary artery disease prevalence in that particular country or in a particular group of population. Let us say of a particular state. Let us say you're talking of Punjab. Let us say you're talking of Telangana. Let us say you're talking of Tamil Nadu. So what is the average food consumption over there? Average sale of fatty acids or fat or oil consumption of the state, and the average rate of coronary artery disease in that particular state. So we are not talking of individual, we are talking of the population. So the unit of study, that's important. The unit of study is a population. Unit of study is a population. That's important. Ecological study is a population based study. It is an analytical study. Analytical study design, and ecological study has a special bias that is called as analytical study. Ecological study has a specific bias that is called as ecological fallacy. What is ecological fallacy? It just means that the results of the study are not applicable at all over. Right? Okay, let's move on to the next MCQ. So I think we all have covered population based study is what is population based study is what is a nested case control. So question number 7, option number 7 goes with option B. So that's how it is. And sir, for atypical diseases, what is the study? Rare diseases, right? Rare diseases we already did. It is case control study. Let's move to the next MCQ. We have a couple of more MCQs coming down the lane. Case control study is useful for today. I think we will be going on till late because we have to complete epidemiology, screening of disease, and biostats into this session. So anybody who's hungry right now, you can grab something to eat. And in case you are okay, we will be spending some time just to finish whatever I have defined in this session. Because if the exam is still there on 11th or 12th, whatever date it is, and whatever date it may be, it may be extended, it may not be. The time is still important, right? You have to finish the syllabus that is defined. Let's move on to the next MCQ. Case control study is useful for. It is useful for finding a rare case, useful for finding a rare case, finding multiple risk factors, finding incidence, finding morbidity. So finding morbidity is not the right answer. Option A is not at all the right answer. Why? Because this is a cross-sectional study. Cross-sectional study. Finding incidence is also not a correct answer because it is the work of a cohort study. It is the work of a cohort study. So you're asking for multiple risk factors. This can be true. Finding a rare case. Case control study, you find a rare case, answer is false. So many of you have answered A over here. You don't find a rare case. It is a study of choice for rare diseases to find what is the reason. So case control study is for finding the risk factor or to find the association or to find the odds ratio. है ना. Case control study is to find the odds ratio or the association or finding the risk factor for a particular disease. I don't think you should be answering that it is used for finding a rare disease. It's not used for finding a rare disease. So finding multiple risk factors, this in fact is one of the definitions of case control study. You take people with disease and you ask them for multiple risk factor. Did you do this? Did you do this? What was this? What was this? This is everything is a case control study. You can ask for multiple risk factors. So multiple risk factors can be assessed in case control. Multiple outcomes can be assessed in cohort studies. I'll write it down for you. Multiple risk factors are assessed in case control studies. Multiple outcomes or diseases are assessed in a cohort study. So sometimes the MCQ wala will make MCQs, googly MCQs on this also. So what is the best answer you would like to mark over here? Finding multiple risk factors, that is the best answer. Many of you had answered A over here, which unfortunately is not a very good answer to mark. Let us move over to the next MCQ. Confounding variables may be treated by all except. So what do you mean by confounding variable? Confounding variable is a variable which is a third variable. Confounding variable. So what do you mean by a confounding variable? It is a third variable which affects both the risk factor and disease which was under the study. So it is a third variable. How do you treat confounders? How do you treat confounders? The confounders can be of two types. Confounders can be of two types. We can have known confounders or we can have unknown confounders. The known confounders are treated by matching. And the unknown confounders, they are treated by RSSR. Randomization, standardization, stratification, regression. So RSSR, randomization, standardization, stratification, regression, these are four modalities to treat unknown confounders. Matching is for known confounders. Please note that there could be MCQ about randomization. Randomization is also called as a universal treatment. It is also called as a universal treatment. It is a treatment for many types of bias. It is a treatment for known confounders. It is a treatment for unknown confounders. So what did I write over here? I wrote down that if you get a MCQ, which is the best treatment for known confounders. So for known confounders, the first option you should mark is matching. The second option you can mark is randomization. But the best answer, single best answer should be matching. Randomization is like a paplu. It is like your hukum ka ikka. It can fit anywhere. So randomization is hukum ka ikka. It can fit anywhere. You just put it anywhere. That is what is the use of randomization. Randomization also removes selection bias and therefore we say it is a treatment for bias. It can be used for known confounders, unknown. It is one of the best things, main things or the core things of a randomized trial, that is a randomization. So confounding variables may be treated by all except matching, yes. Randomization, yes. Standardization, yes. Confounding variable cannot be treated by blinding. That is your best answer over here. All except, why? Because it's all except, right? Confounding variable cannot be treated by all except blinding. Let us move to the next MCQ. Relative risk can be obtained from, just now we have done it many times. Relative risk can be obtained from case study, cohort study, case control study, or an experimental study design. What do you think? Relative risk cannot be calculated from, can be calculated from. So case study, it's not the correct answer because these are descriptive studies. Cohort studies, yes, we can calculate the relative risk. Case control study and experimental study, these are not the correct answers. So best study over here is a cohort study design. Relative risk can be obtained from a cohort study design. So Shoaib has asked, what is the best treatment for unknown confounders? For unknown confounders, the best treatment or we don't say about the best treatment, the best would be regression. Best will be regression, but most commonly we use stratification. Very commonly we use stratification. There's nothing called as best in treatment of unknown confounders, but yes, very commonly we use stratification. But of course, the ultimate thing would be using a statistical method, that is a regression analysis. There's nothing called as the single best answer, but especially in unknown confounders, you can use randomization, standardization, stratification, regression. You can use anything. But very commonly we use stratification and regression. Regression is a statistical way, and stratification is just a way to do sampling methods. So let's move over to the next MCQ. Blood pressures was measured. So now we switch over to your biostats now. Blood pressures was measured for 200 persons. The first quartile BP was 94 mmHg and the third quartile blood pressure was 110. How many persons will have a blood pressure between third and fourth quartile? So blood pressure was measured for 200 persons. The first quartile was 94. The third quartile was 110. How many people will have the BP between third and fourth quartile? What do you want to say? How many people will have BP between third and the fourth quartile? $50. So absolutely correct. Many of you, I think, have got this point that whenever we have a data, let us say that this is the data. So this whole data, I can divide the data into various groups. So let us say this data is there. I can divide it into 4 groups, equal groups. So this is the quartile first, second, third and fourth. Okay. So this question is saying that blood pressures was measured for 200 people. So total people were 200. The first quartile, second and third. The first was at 94 mmHg. The third was at 110. First, second and third, 110. 110. How many persons will have BP between the third and the fourth quartile? So third and the fourth, that is total, is they are asking about this thing. So total they are asking about this value. Please note that this was 200 people. So each quartile, they are asking technically how many people are there within the fourth quartile. So answer would be 50. So absolutely correct. Answer is 50. There could be a couple of questions on this. Please note that if we are talking of a quartile, so this quartile 1, quartile 2 and the quartile 3, there are 3 intercepts in this. The difference between the first and the third, this is called as the interquartile range. This is called as the interquartile range, that is the between the Q1 and the Q3. The Q2 will be called as the median point. So in this MCQ, which was there previously, in the previous MCQ, you had received that the first quartile was 94 and the third quartile was at 110. So technically they had given you 94 and 110. They had given you 94 and 110. So they had given you the interquartile range. So Q3 minus Q1, that is what is interquartile range. Please note that this can be sometimes an MCQ. So absolutely correct. The best answer over here is 50. Coming to next MCQ. A study was conducted on 2 different samples. The sample A had a mean value of 110 plus minus 11, while the sample B had a mean value of 18 plus minus 3. So which of the following statement is correct? Variation in sample A is more than sample B. Variation in sample B is more than A. Variation in sample B is approximately 4 times of the sample A. It cannot be uncertain from the above information. What do you want to say in this? Shoaib says, sir, please tell quartiles plus box whisker plot. MCQ came in INI set. Yeah, we'll be discussing that. Although that same MCQ has been discussed in your, just search for INI set recall MCQs by Mukhmohit on YouTube. So you will get the recall session MCQs also, We already discussed that much in detail over there in that particular video. Anyways, we'll try to do that. I have one question with us today also. A study was conducted on two different samples. The sample A is there, sample B is there. So the mean value of sample A has a mean value of 110 plus minus 11, whereas the sample B has a mean value of 18 plus minus 3. Which of the following statement is correct? So Nandakishore says option B. Roy Chaudhary also says option B. How did you calculate option A or B or D? What do you want to say? Variation B is more than A. It cannot be ascertained from the information provided. Okay. Whenever the question will ask you about variation is given by a formula SD over mean into 100. Okay. Variation is given by the formula SD by mean into 100. In this MCQ, they had given you two samples, sample A and sample B. Sample A and sample B. Sample A has 110 plus minus 11 and 18. 18 plus minus 3 and 110 plus minus 11. Okay, so let us calculate the variation in sample A. The variation in sample A will be given by SD over mean into 100. So what is the mean value over here? It is 110. It is 110 multiplied by 100. That is what is variation. So 0 is cut. So it is 110 over 11. It will be 10. 110 over 11. It will be 10. And in the sample B, it is 3 over 18 into 100. So 3 ones are 3, 3 6 are 18. So 1 by 6 into 100. 6, 1, 6, 40, around 16 and something, some values. Okay. So it's around 16. It's around 16 point something. So you have a variation in sample A and you calculate the variation in sample B. We understand that the variation in B is more than variation in sample A. Are we okay? So the best answer would be variation in B is more than A. Why? Because the variation is more in sample B compared to sample A. There is also something called as variance. It is different from variation. Variance is SD square. So please note that variance is entirely different story than variation. Variation is something else and variance is something else. So that you have to calculate the variation. This is called as coefficient of variation. Absolutely correct. So in this option, we are going to mark sample B is more than sample A variation. So I think that which of the following statement is correct? The option B is the correct statement. Let us move over to the next MCQ. In a normal distribution curve, the area between standard deviation on the either side of the mean is equal to the area in a normal distribution curve. In a normal distribution curve, the area between three standard deviation on the either side of the mean will be equal to 99, 95, 75, 68. What do you want to say? So it's a very easy direct MCQ. In a normal distribution curve, the area between three standard deviations on the either side will be equal to 95, 99, 75 or 68. Well, the answer over here is absolutely correct. 99% of the population, 99% of the population is going to lie within the three standard deviations. So absolutely correct. Many of you have given it correct answer that within the three standard deviation. You know that this is the normal distribution curve. In the normal distribution curve, the center point is what is the mean. Absolutely correct, beta. The center point is what is the mean. This corresponds to the mean in a normal distribution. This will be equal to the median. This will also be equal to the mode. So plus minus 1 standard deviation on either side. This will be plus minus 1 standard deviation, plus minus 1 SD will be equal to 68% of the population or 68.23. Plus minus 2 standard deviation is 95.45 or 95% of the population, and plus minus 3 standard deviation will be 99.73, or you can just remember it as 99% population. So on either side, 1 SD 68, 95 and 99%. So the best answer over here will be, they've asked about the 3 standard deviation. 3 standard deviation will be 99% of the population. Everybody is answering this correctly, absolutely correct. Let's move on to the next MCQ. Calculate the 95% confidence interval for a study on post-meal glucose level in 100 individuals with a mean glucose level of 210 plus minus 10 milligram per deciliter. So calculate the 95% confidence limit range for a study on post-meal glucose level. What do you think you're going to answer over here? So will the answer will be 190 plus minus 230, 208 to 212, 200 to 220, 205 to 215, 205 to 215. What do you think you're going to mark over here? So yeah, many students are going with option A. Nandakishore A, Pranshil says A, Shoaib says A. Very nice. So the mean glucose levels is given as 210. 210 is given as the mean glucose level. So you're going to find out what? You want to find out 95% confidence limit or the 95% confidence interval. I know that many of you are trying to answer it based on your understanding that you will take plus minus 10 SD. So unfortunately, that's not the correct way to do it. Whenever, please mark it. This was a googly. Many of you are answering option A over here. So which is unfortunately not the correct answer. This is not the correct answer. Option A is not the correct answer. Let's have a look at what happened wrong over here. So there's only one B I can say by Roy Chaudhary. So that's the correct answer. Let's just see how to solve this question. So B is the correct answer. What happens is whenever the question will ask you about confidence intervals, or the question will ask you about the confidence range, or the question will ask you about the confidence limits. Whenever the question will ask you about the confidence interval or the range or anything, please note that you do not need to take directly the standard deviations. You talk about the standard errors in those cases. Standard errors in those cases. So you have to calculate the standard error. Standard error can be calculated for mean and standard error for proportion. The standard error for mean is given by the formula SD over square root n. Whereas the standard error for proportion will be given by the formula PQ over n whole under root. You do not need to talk about the standard error for proportion in this MCQ because this question is giving you the mean. This question is giving you the mean. So we are going to calculate the standard error for mean and not the standard error for proportion. What is P over here? Just for your knowledge, what is P? P will be given by the prevalence. So whatever prevalence the question will give you, you need to put that. Q will be 100 minus prevalence. N will be the sample size. Okay. So this is not required in this MCQ. I'm just telling you just for the sake of your knowledge that you should be knowing what is a PQ by N. You should be knowing how to calculate the standard errors. You should be knowing this. For standard error for mean and proportion. Okay, so now if you are done with this, let us find out the standard error for mean in this MCQ. So how will you find out the standard error for mean? You already know that the standard error for mean is given by the formula SD over square root n. So that will be SD is given as 10. So it will be 10 over square root of n. What is n? N is 100. Sample size is what is 100, right? Sample size is 100, whereas the standard deviation is 10. So you do 10 divided by 100. 100 will be this thing. So 10 over square root 100. That is 10 by 10. That is 1. So standard error for mean is given by 1. So simple question now. To find out the 95% confidence limit, you will take out 210 plus minus the standard error for mean. That will give you the 95th range. So answer will be 210 plus minus 1 standard error. So this is going to give you the confidence limits, or this will be giving you the confidence range. So what is your best answer? Do you want to change your answer now? So the question had asked you about the 95% limits. What is the 95%? 95 will be 2 standard errors, right? So 95 will be, so this is your mean. So this is plus 1 standard error, plus 2 standard error, plus 3 standard error. On the back side, you will have minus 1 standard error, minus 2 standard error, minus 3 standard error. So the mean, you already know that what is the mean. In this scenario, they have given the mean as 210. So standard error, 210 plus minus 1 standard error. Standard error is how much? 1. So over here on this side, what should I write over here? It should be 211, 212, 213, 209, 208 and 207. So what is the best answer over here? The 95% confidence interval range will be given by 208 to 212. 212. That is your best answer. So what is the best answer over here? 208 to 212. Unfortunately, it was a difficult MCQ. It's a googly type of MCQ which have been very frequently asked, especially in your exams like INS set exam. It is not of the level of NEET exam. It is only, I would like to mention over here, you are supposed to do these type of MCQs only in your INS set level. That also maybe can be asked. It's not a very high yield. I am not saying beta that this is a very high yield. If you don't know this, you are gone, you are doomed. Nothing of that sort. This MCQ is a high level MCQ. There is a rare chance that this MCQ can come, but if it comes, you should be prepared. That's all that I wanted to say. So whenever the question will talk to you about the confidence intervals or the confidence limits, or the question will talk to you about the p-values, in those situations, do not use standard deviations to find the 95% range. You need to use the standard errors. That is the take-home message. I am saying it again, beta. This MCQ was a difficult MCQ. There is a less chance that this question can come in your exam, but at least if it comes in your exam, you should be prepared with this. That's all. So otherwise, it's a low yield. If you don't know this, very nice. That's okay. Keep it cool. Keep it simple. Let's do the easy stuffs. It's not required to do the difficult stuff all the time. Hai? So that's fine. That's absolutely fine. Let's do this question. I think you all will be able to do this. Let's do this and finish off this module right now. Identify the type of distribution. What do you think you're going to answer over here? What type of distribution is this? Normal distribution, positive skew, negative skew, or a binomial distribution. So whenever this question will talk about skews, skew could be of two types. Skew means not a normal distribution, hai na? So skew could be something like this, or skew could be something like this. When, let us say, on this axis, on the horizontal axis, this is low values, or these are the higher values. These are the low values, these are the higher values. So whenever most of the values are towards the lower range, that means towards the lower range, that means the extreme is towards the higher range. This will be called as a right skew. Please always look at the tail. Look at the tail. Wherever the tail is, if the tail is towards the right, it is called as a right skew. If the tail is towards the lower values or the left side, it will be called as a left skew. It will be called as a left skew if the tail is towards the lower side or the left side. Please note, you always have to look at the tail, never look at the mountain. If you look at the peak values, if you look at these peak values, you will get confused. So always look at the tail. Okay. So based on this only, there is another concept that is called as a box and whisker. Box and whisker. If I show you a data with a box and whisker, see, I talked to you about the quartiles. You remember the quartiles? So you have quartile 1, quartile 2 and quartile 3. So let us say that this becomes as a designer kind of thing like this. This is called as a box and whisker. So in this, obviously, I think everybody knows this is the median. This is the quartile 1, this is the quartile 3, right? The median is the quartile 2. So quartile 3, quartile 1, and the median is the quartile 2. Okay. So in the box, how many people are going to lie? 50%. In the first range, in this range, how many people are going to lie in the yellow shaded zone? 25%. In this red shaded zone, another 25%. So 25%, 25% are going to lie here. Are we okay? This is a simple box and whisker. Now, if I want to show you another type of box and whisker, if I just show you another type of box and whisker, let us say that this is the box and whisker and this is type 1. Let us say I want to show you type 2. In this, the box is like this and the value is like this. So what do you comment on this box and whisker? So there's a third type of box and whisker which will be something like this. I told you, let us assume that these are the higher values and these are the lower values. These are the lower values, this is the higher values. So most of the population in this graph 2, you know that the box contains 50%. This will contain 25%. So the total 50 and 25 makes 75. So can you see that 75% of the population is going to lie within the lower range only? So can I make a chart like this? Can this look like this? On the other hand, if I show you the lower curve, the third number curve, you see that 75% population is within towards the higher range only. So can I show this curve something like this? Are we okay? So that means these are different types of skews. So if the box is towards the lower side, that means this tail is towards the higher side. So the tail, you have to look at the tail. This is a right skew. This is a right skew. It is a positive skew. Whereas if the tail is on the left side, it is called as a left skew or a negative skew. Left skew or a negative skew. Negative skew. Are we okay with this? So now if you understand this, what is this skew beta? What is this curve that you're seeing? If you understand this, it's very simple. It's very simple. You can see that the skew has come towards the lower side. If it has come towards the lower side, it is a left skew or a negative skew. It is a left skew or a negative skew. So what does this identify, this type of distribution? The best answer over here would be, this curve has not gone towards the lower or the left side. It's the tail which has gone on the upside. So sorry, it's not the negative skew. So this will become something like this, right? So the tail is towards the higher side. The tail is towards the higher side. So I also just did the reverse. I want you not to do this mistake. The tail is on the higher side. If the tail is on the higher side, that means this will become a right skew or a positive skew. Sorry for the mess up over here. It is a right skew or a positive skew. Please note, it's very easy. It's easy to identify. This is a positive skew or a right skew. I would like to mark positive skew as the best answer over here. Right? Let us move to the next MCQ. Direct MCQs, no big stuff. Criteria for applying a t-test is just 2-3 more MCQs and then we'll be off with it. Criteria for applying a t-test is, when will you apply a t-test? T-test. T-test is a test of significance. Test of significance. Test of significance. So t-test, please note, it is a test which is used for quantitative data. Quantitative data. Quantitative data and not for qualitative data. It is done for random samples where the random sampling is done. Random sampling is done. So it is not for the non-random sampling. Variable asymmetrical distributed is wrong. It is for symmetrical distribution or a normal distribution data. Normal distribution data. And the best answer you would like to mark is sample size less than 30. So So what is this answer? Criteria for applying t-test. Criteria for applying t-test is, the best answer over here is sample size less than 30. Sample size less than 30. Please note that if the sample size is more than 30, then there is a special test that is called as a Z test. There is a special test that is called as a Z test. So many of you have answered this correctly. Absolutely correct. Just a very quick review about the test of significance. So if we give you scenarios, let us talk about some of the scenarios, like single group is there, two groups, or three or more groups. So for single group, if it is a parametric test, what do you mean by parametric test? It means parametric test, that means for quantitative data. Quantitative data. Parametric test means quantitative data, non-parametric means qualitative data. So that means for quantitative data, we will do a paired t-test for single group, unpaired t-test for two groups, and many groups we do ANOVA test. ANOVA test. Non-parametric data or the qualitative data we will do for single group McNemer test, two groups chi-square test, many groups we will do Kruskal-Wallis test. So absolutely correct. Many of you have answered it correctly. Sample size less than 30 is for t-test. Sample size more than 30 will be for Z-test. Let us move to the next MCQ. This was the question which was discussed yesterday, I think, and it was yesterday or today only. I don't actually remember. On the Telegram group, we had a question discussion on this. So in a study, two groups of newborns were assessed. So group A and group B, based on the low or normal birth weight. So in a study, two groups of newborns were assessed, but the crux of the main problem in the story is based on the low or normal birth weight. So based on the low birth weight or a normal birth weight, that means you are dividing the population into two parts, low birth weight or a normal birth weight. That means what type of data is this? Is this a quantitative data or a qualitative? I'm waiting for your answers in the chat box. So based on the low or normal, you divide the whole population into low birth weight babies or normal birth weight. So answer is, it absolutely correct. It is qualitative data. You're dividing into the qualitative data. And intake of the nutritional supplement, yes or no by the mother also. So that means it is purely you're talking of the qualitative data. The qualitative data, whenever we are talking of two groups qualitative data. So the answer has to be a chi-square test. Just now we have discussed the answer has to be a qualitative test. But based on the low birth weight or the normal birth weight, it's not a quantitative data. It will be a qualitative data. Qualitative data. So absolutely correct. Many of you have got it right. So the answer would be a chi-square test, because you are doing two different groups are tested in this question. Two different groups will be tested, and you divide them into two groups and you check for their test of significance. The answer would be a chi-square test, right? Last question to close off this whole scenario is the p-value of a randomized trial. I know this is a difficult MCQ, beta. It's again a difficult MCQ. A p-value of a randomized control trial comparing operation A and operation B was 0.04. So from this we conclude that. What do you want to say? Type 2 errors, I'll read it very slowly and I'll be waiting for your answers. Type 2 errors is small and we can accept the findings of the study. The probability of false negative conclusion that operation A is better than B when in truth it is not is 4%. The power of a study to detect the difference between operation A and B is 96%. The probability of false positive conclusion that the operation A is better than B when in truth it is not is 4%. So what do you want to say? Option number 1, 2, 3 or 4. So you have option 1, 2, 3 and 4. Which of the following options are you going to mark? I know this is a difficult MCQ. It is a slightly difficult MCQ and many of the probably the PG students also Sometimes they take time to answer this, but of course everybody would be able to answer it. So we've got the first answer from Shoaib, option D. Shoaib bhai, sorry, वो दिमाग घूम गया आपका यार. That was a small mess up I did. That's okay. So you were correct. Your funda is correct. So everybody is answering option 4 over here. That's interesting. So Nandakishore also goes with option 4. That's very interesting. I'm so proud of you. You all are answering it correctly. That is the correct answer, option number 4. So the probability of false positive conclusion that operation A is better than B when in truth it's not is option 4. So points, I'm proud of you. So thank you so much for answering this correctly. A few points about p-values. Whenever we are talking of a standard normal distribution, we are talking of the z-scores or we talk of the standard errors. Please note that the p-value at 2 SE, technically at 1.96 standard errors, which is roughly corresponding to 2. This point corresponds to a p-value of 0.05. So similarly on this side also p-value of 0.05. Anything, mark my words, anything which falls within the 2 standard deviations is taken as the normal zone. So p-value at the center point will be equal to 1. P-value at the center point is equal to 1. So if the p-value as per this study comes out to be 0.04, that means what? P-value in this study is 0.04. That means within the normal range or outside the normal range. It is outside, so it is somewhere 0.04. This is where this p-value is lying. It is lying outside 0.04. It is lying outside the normal zone, because from 1 till 0.05 is this range, and it is lying beyond this range, right? Are we okay with this? So now anything which lies outside the normal zone, these p-values which is outside the normal zones, this is the normal zone, this is called as a significant p-values. These are called as a significant p-values. So any p-value which is less than 0.05, that is called as a significant p-values. So what does this p-value mean? But it simply means that whatever effect you are observing, if it is 0.04 p-values, it means that there is mark the words very carefully. It just means that whatever difference you are observed, if you say that this is a pen, if you say that this is a blue color pen, if you say that this is a phone, if you say that this is a spectacle, so anything that you say that this is this, there is a chance that you are wrong. Are we okay with this? So whenever we do a study, at that time also there is a chance that we might do some errors. So let us say you observe something. Listen very carefully. What is the chance that you are observing a thing just by chance, which in reality was not there? So what does p-value tell you? It tells you about the probability of observing an event just by chance, which in reality was not there. This concept is what is p-value. It is related. Whenever you talk of the p-value, it will be in decimals. So it is related to something called as the alpha errors, which is nothing but the probability. It's the chance in percentages. So alpha error will be 5% at p-value 0.05. Alpha error is 4%, or the probability or the chance will be 4% at p-value 0.04. So p-values, just to summarize, there's just a summary point. Just to summarize for you, p-values less than 0.05 is significant p-values. They corresponds to alpha errors. It relates to the probability of finding an effect which does not exist in reality and was observed just by chance. It was observed just by chance, it did not exist in reality. That is what is the funda of p-values. So if you understand this, type 2 error is small. Let us talk about these options now. Type 2 error is small and we can accept the findings of the study. Type 2 error is not related to p-values and we cannot comment on this. We cannot comment upon the type 2 errors. P-values are related to alpha errors. Alpha errors are what are related to type 1 errors. So p-values, alpha errors, type 1 errors, the concept is same. So we cannot talk about the type 2 errors. This option is wrong. 1. Let us talk about the option number 2. The probability of false negative conclusion that operation A is better than B when in truth it's not is 4%. So the probability of false negative conclusion, that is also not a correct answer. Why? Because it's not talking about the false negative. See, please note that alpha errors are what are type 1 errors and they correspond to what are the false positive errors. So they correspond to the false positive errors. They're not talking about the false negative errors. Option 3, the power of a study to detect the difference between operation A and B is 96%. So what do you mean by power? Power of a study is given by the error. It is 1 minus beta error. Beta error is what is type 2 error. So p-values is related to type 1 error or it is related to false positive error. It is not related to the beta errors or the type 2 errors. So beta errors, type 2 errors we cannot comment. Power of the study we cannot comment. So that is also option false. Option number 4, the probability of a false positive conclusion. The probability of a false positive conclusion that the operation A is better than B when in truth it is not, when in reality it's not there, is 4% is the correct answer. This is the correct answer. Option number 4 is the best answer over here. So let me look at what all comments are there. You all have answered it correctly. Yes, that's correct. So null hypothesis is true but rejected. Null hypothesis is true but rejected. This is alpha error or type 1 error. So absolutely correct, Nand Kishore. Null hypothesis is true but rejected. Naved Ahmed, p-value is beta error less than 0.0.5. Nah, it's not about the beta error, beta. Naved Ahmed, p-value is not related with the beta error. P-values are related with the alpha errors and it's not with the beta errors. Beta errors are related to the power. Power is given by the formula. Power is given by the formula 1 minus beta, whereas p-values, they are related with the type 1 errors or the false positive errors, or technically we call them as the alpha errors. So the best answer should be alpha errors. They are not related to the beta errors. So I think this question was the last question, and that was regarding the p-values or interpretation of the p-values. Last MCQ, just before we take off, call it off, and ask about the doubts. Identify the following graph. What do you think about the graph? It's a spot map, pictograph, geomap, or a choropleth graph. So what do you think is the best answer over here? Identify the following graph. What you can see over here is our country. We have divided into different states, and some states are shaded more, some states are shaded less, and there is a legend also which will tell you about what is the value of each shade color. So what do you think is this graph? So this graph, absolutely correct. Many of you have got it correct. It is, Akib Khan says option D. Beta, this identify the following graph. This graph is technically called as a choropleth graph. Geomapping is used in choropleth. This is not the name of the graph. Geomapping is used in choropleth in making a choropleth graph, and pictograph is not the correct answer. Spot map is not the correct answer. We just shade different portions of a country or of a state accordingly, depending on the prevalence in that or morbidity in that place. So it is a choropleth graph which uses geomapping, or we also use GIS, Geographic Information Systems. Geographic Information systems. We also use geographic information systems to and GIS mapping or the geo mapping to find out the choropleth graphs. This is the best answer, choropleth graphs over here. So with that, we close off this session. Any doubts or anything you would like to ask, you're most welcome to ask. In this session will be open for discussion. And you had also asked about whether the session will be available online, yes or no. Unfortunately, this session will not be available after the 12th of March. And that is the time that this whole series of Mission Indradhanush will be used till. So all the students are advised to look into these series as soon as possible, because they would not be available after the 12th of March. And regarding the news, I'm not very sure about the news, but you all must be aware about the news. Whenever the exam is beta, all the very best for your exam. Keep on preparing hard. We are just towards the last session of completing community medicine lectures. Any doubts, you're always welcome to ask me on this Facebook group. You have the Links group, the wonderful Links group. You can also push in messages directly on my group, that is Mukhmohit's Community and Medicine Discussions, or you can preferably join the Telegram group. So thank you so much for watching this session and staying alive with me all through the epidemiology and biostats portion. I wish and I hope that this session was useful to you, and there should be MCQs in your exam. Take care, keep on revising, and good night. There's one MCQ doubt. Sir, in MCQ there is a line, power increases when the alpha increases. Can you explain it? Is it important? In the MCQ there is a line, power increases when the alpha increases. Where is it written? It's nowhere written. Power will be equal to, power is related to the beta error. Please note, power is related to the beta error and it is related to the type 2 errors. It is based on sample size. It is something which is related to the sample size. Power is entirely different and independent of the p-values. P-values is different beta. Alpha errors are different. Type 1 errors and p1s and p-values and alpha errors and type 1 errors of false positive, they are almost the same. So Nand Kishore, please note that power is 1 minus beta. That is important for your exam. That's all that you need. So what is control group event rate? Beta Soumeshri, we have already discussed about the MCQs from the absolute risk reduction. Just search for number needed to treat. Number needed to treat. So if you search for number needed to treat questions, we already discussed, couple of questions had been coming in the last INS set exam. So you need to just assess to that what are the different formulas. So whenever this is the, let us say that these are the people with disease, or you can say about the event. Let us say event happened and no event, and you are giving COVID vaccine to a group and there is no vaccine to another group. So number of people who get the event with the vaccine, and there will be people who get no event even with the vaccine. There might be people who get the event without vaccine also, right? And there might be people, of course, there will be many people who do not get the event without the vaccine. So this becomes my control group. So this becomes my control group. This is my control group. This becomes my experimental group. Experimental group. So now I want to find out the event rate in control group. Event rate in control group. So what will I do? What I can do is A, B, C and D. So what is the event rate in control group? Event rate in the control group will be C over C plus D. This is called as control group event rate, CER. Can you tell me the event rate in experimental group? Event, the chance of having event in the experimental group, that will be A divided by A plus B. That's what it is, A over A plus B. This is called as EER, experimental group event rate. So now if I just subtract the control group event rate minus the experimental group event rate, this is called as absolute risk reduction. This is called as absolute risk reduction. And now if I want to calculate the number needed to treat, this was the question in the last 3 INI set exams. Last 3, every year you got this question. So number needed to treat is given by the formula 1 over absolute risk reduction. That means 1 over control group event rate minus experimental group event rate. Simple. So you just need to memorize that. It will be very simple MCQs. Very simple MCQs, but only if you know this formula. If you know this formula, you will be able to answer these MCQs. Otherwise, it will become a big problem. You will get very much scared that what is happening, why are we getting these MCQs? So it's just a simple funda for you to remember that you have to find out the number needed to treat. Number needed to treat is given by the formula 1 over absolute risk reduction. It's not attributable risk, it's absolute risk reduction, which is nothing but CER minus EER. So that's what that is required. So I would like to thank you again for your lively attention and for asking all your doubts, and I hope I was able to address to all your queries and your controversies and your doubts. Take care and good night.